Okay, so this is the survey that the patients presented with every day. And so we can see there's a couple of things to note here. There's always a reminder that if they have really severe symptoms or that they're concerned at any point and it's a medical emergency, they should call 000. This tool is not a replacement for those emergency pathways. And so that's the messaging that we're conveying to the patient the whole time as well. It reminds the patient that they've had a positive swab. There's some capacity for patients to track their symptoms over time. So you see the different symptoms listed here and they can watch the trend. And then really just runs down particular symptoms of concern, really looking for any evidence of development of severe disease or severe complications. And then at the end of those questions, they can record the observations and move on. Additionally, there's recent test results are listed down here. So if we have them on the system, they'll be visible to the patient there. And there's some additional resources, so some DHHS resources, then also some translated resources, and also some domestic violence and isolating with family resources as well. And then whilst this is a bit of a busy table, really the idea is that within that symptom survey, there is a severity scoring system, which you can see is color-coded here. So really each of those symptoms, these are all the different options broken across, and then they run from the least severe through to the most severe. And really the idea of this, and this is not conveyed to the patient necessarily, but this is what's visible to the clinician at the other end. So the goals of this tool being delivered every day, really the primary goal is actually to clearly identify those patients with either no symptoms or very mild symptoms, so that we can be reassured that patient is doing well and dealing with their illness. Then the secondary goal really is to provide a very sensitive method of detecting early deterioration, but without being too specific. So you'll actually see that a reasonable number of the moderate symptoms, what we have found is that when you call the patient, they may not sound quite as severe as they're initially labelled here in this table, but that was really designed intentionally so that we make sure that we capture everyone who's deteriorating without actually being too specific and excluding anyone. And really, this severity scoring system is more around being a guide for clinical escalation and a guide for triaging follow-up, rather than necessarily being very, very specific and saying this absolutely is a dire situation if someone does report a severe symptom. The survey tool has some additional functionality as well. So if you have a thermometer, you can record your temperature. There's a clinical breathlessness assessment that does not feed into the severity scoring, but is there as an adjunct measure, particularly for those with chronic respiratory illness. And there is capacity for capturing remote oximetry data as well if a patient has an oximeter. In addition to this, in liaison with Austin Respiratory, particularly with patients with chronic respiratory illness, we can provide oximeters to patients that they can use to record their oxygen saturations, but this is very much on a case-by-case basis. So to date, we've been using this tool since March 31st, so through both the first and second wave. We've actually had over 28,000 people run through our program internally, so completing a minimum of 14 days follow-up with this. And of those, more than 400 COVID positive patients have been included. I think it's worth stressing now that this is a new development to be having care taken up by clinicians in the community. It's just worth reflecting on the fact that of those 400 patients, we've really had an estimated 200 episodes of severe symptoms, and that's only 3.5% of all symptom submissions for COVID positive patients. So certainly still it is the vast minority of patients that are having severe symptoms that they're reporting. And it's also worth noting that even when patients have been submitting the quote unquote severe symptoms, most of those episodes have not required in-person clinical review, so review in our screening clinic or admission. That doesn't mean that we're not assessing them thoroughly and still escalating as required, but it's just, I think that's reassuring to see that the vast majority of patients, even with reported severe symptoms, have then actually not needed dramatic escalation. That being said, this tool has allowed us to identify early deterioration and early admission and treatment. So we've identified a number of secondary bacterial infections, a number of episodes of pulmonary embolism, and also an episode of pneumothorax. And really that early intervention has avoided ICU admission for these patients, which has been fantastic. It's worth noting with those ones that principally those have been in patients that meet those medium risk criteria and will be followed up by the Austin automatically anyway. So how we monitor these the patients and their reported symptoms is through a digital dashboard called COVID Monitor, and really this just gives visibility over the data that that COVID Care, the daily symptom tracking, is generating, and that data is presented specifically to the different users. So, for example, Austin Health will have visibility over the data of patients being monitored by Austin. A specific GP practice will have visibility over the patients as being reviewed by that GP practice, and similarly community health, a community health service. There are real-time updates, so as a patient submits symptoms, they then become visible on each of the relevant lists. And there are follow-up lists within COVID Monitor, and I'll be running through this in more detail for you, whereby you can clearly see anyone who's reporting any symptoms of concern, and then use that symptom severity scoring to triage the review process, so who gets a call slightly earlier than anyone else. The broad inclusion criteria of what is presented on those follow-up lists is that it's anyone with severe or moderate symptoms, which we can see here, or anyone that hasn't been followed up within the last 48 hours. So within the Northeast pathway, really the expectation is that all COVID positive patients, whilst on the pathway, will be followed up every 48 hours or more regularly if there are symptoms of concern. So going on from that, so the responsibilities for the clinicians, whether they be within Austin or externally, is that there's an initial review, as Alison had mentioned, and so that's separate to the triage step. That there's review of the daily self-reported symptoms, and same-day assessment of any symptoms of concern, and otherwise second daily assessment of all COVID positive patients. That then there's a responsibility for escalation of deterioration with patients with either clinical or social concerns, and then finally identifying any patients who may be eligible for de-isolation and then flagging that with Austin to undertake the de-isolation and clearance step. In terms of, I sort of briefly mentioned the reporting responsibilities, so the vast majority of the reporting will be undertaken by Austin through the data that we're capturing through these tools. The two that we are not going to be reporting directly would be any serious adverse events or deaths that occur that are patients that are not being cared for by Austin directly. So because there are already routine mechanisms for that reporting. That being said, as part of the pathway, would expect that that community partners notify the Austin of any serious adverse events or deaths, and then we can provide higher level reporting back to DHHS, but not specific to those cases. Okay, so how do we actually get partners in the community onto the system? Our community health centres have already been linked in and have started the social and welfare reviews. And I just thought I'd outline here the process for any GPs. So what will happen is once the patient's been triaged, they've been identified as low risk and that they do have a GP. So then at that time, there'll be a telephone referral from the Austin to the GP seeking consent for taking on the patient's care as part of the pathway. And if they do, then the information that we need is really just a name, an email address, a mobile phone number, and a list of associated practices. The reason being, so the top three are really for being able to actually access the tool itself, using the mobile phone just for two-factor authentication. I'm not going to be spamming you with texts. And then the list of associated practices. So patients will be linked to a specific practice. So if someone works across multiple sites, their login will actually allow them access to see any of the patients on any of those different practices, so that at any one time it's easy if someone's away one day, or if someone's unwell, it's easy for any of the other clinicians in those practices to see the patients that might need following up and be able to cover. So this is what the tool looks like itself, and I can actually run through it. I can run through it live, but I'll just show you briefly. So the menu here that'll be that's visible to everyone in the community. So just to run through, so the social welfare list is just relevant for community health performing the social welfare checks. Then the full list will demonstrate the list of all patients that are active in the pathway and are associated with the GP practice the GP practice that's logging in to see those patients. So this is everyone in the system that's being cared for by that specific GP practice. And if that GP works at multiple practices, then they'll see everyone across those different practices as well. The follow-up list is specifically anyone who's ever logged in. So we know these are people that have access to a mobile, can use it, have data, and have used the tool before. And they either have symptoms of concern or they haven't been reviewed in 48 hours. So we can see here there's a number of different patients, so a couple of them reporting severe symptoms or moderate, and here's someone who's mild symptoms, so normally wouldn't trigger, but clearly hasn't been reviewed in 2 days, so it's popped up onto the list. And then a separate list, this is for patients where we either don't have a mobile phone number and we haven't been able to find one, or they don't have data and aren't able to access it through the tool. So instead, this one really runs on a logic of if they haven't been reviewed within 48 hours, then they'll appear back up on that list. So we can still make sure that we're not losing touch with people who can't directly use the symptom monitoring tool themselves. Going on to the My Details tab lets you change your password. So that initial password, you can then change it to be specific for you. And then I'll just walk through the process of what it looks like once you actually try and once you've assessed a patient. So going to the follow-up list, here's someone that we want to follow up, and you literally just click on the patient themselves, and that brings you to a fairly busy but comprehensive patient window. So all of this is really patient demographic data. It reminds you that they're COVID positive. It says what the severity was of their last reported symptom. So this one's severe, so it's popped up in red. And then over here, we can see these are effectively the tabs that we use to document the outcome of the interaction. So none of these tools are designed to replace anyone's medical records. It's really just about very simple outcome documentation as to, yes, I've contacted the patient, no, I can't, I've tried to leave a message, or no, I don't need to contact the patient. It's just that very simple, that basic level response. Beneath that previous view, then we can see any results that the patient's had, and so red for positives, and then any reported symptoms. So we can see here, right on the 10th, they've reported a symptom, it's severe, so it's come up in red, and then all of their symptoms that they've reported will be listed out here. And so for this patient, it's just the one set, but then all of the separate symptoms listed with the severity underneath. And similarly to before, so any swabs that they've had and when they were, and then a log of all activity, so that if there are multiple people accessing it, it's clear as to who has done what at any one time. So then getting to the actual outcome measures, so how we tick off, yes, I've seen the patient, this is, I've dealt with the issue. So that's really just zooming in on those options across on the side. These dark blue ones are really the key. So this is saying, yes, I've called the patient. So, yep, attended to. No, I've tried to call, but I've left a message. And then there's also a prompt in there that says if we've tried a few times and we're not getting through to the patient, there's a prompt then to escalate that either to DHHS or potentially to Victoria Police for a welfare check. And certainly Austin's always happy to assist in that situation as well. And similarly, it's less commonly used, but on the off chance that, say, a patient has then subsequently been admitted, this is something that we use a bit more often, because we'll see people that are coming in under these high risk ones, and we can just say, yes, we acknowledge that they are still dutifully filling in their symptoms as an inpatient, but that doesn't mean that the outpatient monitoring teams need to address them at this stage. And then there's just a couple of other useful additions. So this purple tab is purely for the social welfare check, so it's just used by the community health teams. You can schedule a specific follow-up. So if someone says, oh, look, I'd rather you called me in 3 days' time, you could set that day, and then they'll automatically come up onto the list, so that you know that whoever's working or reviewing them that day can see them. That being said, if they report any moderate or severe symptoms, that will override that follow-up, so they will still automatically appear. So they're not going to be lost to you just because we've set them a little bit further out. There is the capacity to record some very brief notes, but this is really for the purpose of just very simple communication between the teams and between sites. So should not be used for any medical record keeping. It's really more along the lines of saying, I've left a message, and Morgan will call back. And then finally, once a patient's been identified as having had their illness resolved, we can then click on this tab here for requesting de-isolation and clearance, and that will automatically populate a list for the Austin clinical team to make a phone call to that patient and assess whether they can be de-isolated and then discharged from the program. And finally, there's this button. So if someone just gets very sick of my text messages asking them how they're going, or there's issues with their data and they can't access it, you can actually request that they don't get the texts anymore. This will not discharge them from the program. It just means they don't get the text reminders. So they will still appear on the system, prompting you to call them every 2 days. But at least if they really don't want the text messages, we can turn that off. So assuming that you've been assessing a patient and they're reporting symptoms of concern, how do you actually go about escalating care? And exactly as Alison had said, this is not an exercise in keeping people out of hospital when they clearly need to be here. So Austin Health, and particularly the infectious diseases team, is very motivated to be available and accessible to everyone in the community to assist with this. So for any clinical questions, I am extremely happy to be called. We have a dedicated mobile for COVID external calls that will be manned by one of the ID consultants during business hours. After hours, for any urgent calls, that can go through to the COVID ID consultant on call. And then very happy to have discussions at that point. Similarly, arrange for patients to be seen in our screening clinic. So in terms of in-person reviews, that's how we facilitate things in the Northeast model, is that our screening clinic has a capability to clinically review patients. And then finally, we can escalate to admission either through screening clinic or through the emergency department as required. And if that is required, and we now feel that Austin needs to take over the clinical monitoring of the patient, then we can actually facilitate changing that within the system, so that those patients' symptom reports will no longer go to the GP. They'll be shifted over to the Austin. So there's never going to be a point where the GP's having to try and manage symptoms of a patient that's actually being cared for by a different service. Similarly, for any social or welfare or isolation concerns that arise during someone's care, so during weekdays, obviously being able to have the community health teams as the first port of call, and then really on weekends and after hours with DHHS as the first port of call. But again, with Austin being in a position to be able to facilitate that, and certainly if it's getting to a severe point where someone potentially needs to be admitted because of issues around isolation, then yes, we're always happy to talk about it. So don't be concerned about giving us a call. In terms of the key things, whilst this is not really a discussion of the clinical management of COVID necessarily, really the key complications that we're on the lookout for, and really, as you will see, is a key focus of some of these questions around breathlessness and chest pain, is particularly around severe COVID pneumonitis, so a severe inflammatory viral pneumonia, potential secondary bacterial pneumonia, pulmonary emboli, and then cardiac, so myocardial infarct as well. And really the thing to note is that early in the illness there is the capacity for the viral pneumonitis to be a bigger player, and then as patients progress, and there's certainly something to be aware of around the day 7 to day 10 mark, the capacity for a deterioration in spite of someone having potentially got better over a few days. That's really when we particularly start thinking about the secondary pneumonias, and especially then thromboembolic disease and PEs. So worth being aware of. That being said, as I'd noted, the vast minority of patients actually having severe symptoms as part of their disease process, but they're really the key things that we focus on. Similarly, so say someone has been admitted to the Austin or has been seen in the screening clinic, and we then need to de-escalate back to GP care. So assuming that they are a low risk patient and we're now very confident that they've resolved their acute medical needs, again, there'll be a telephone handover from Austin to the specific GP, and then we will redirect that patient's ongoing self-reported data through to the GP. Once a patient's reached a specific milestone, and really that's once they've reached day 10 of illness and they're currently asymptomatic, then that is really the trigger point for being able to refer the patient for de-isolation and clearance. Now, that's not an absolute hard and fast rule, and so really we use this as a guide, and so certainly anyone that's achieved that, very happy to then assess them for de-isolation and clearance. And then anyone else who is approaching 2 weeks of their monitoring, then very happy to have a discussion and make an early assessment as to whether we think that they should be sent for clearance. And so what we would expect the community clinician to do at that point would then just be to click this tab here, and they will automatically populate them on a list for the Austin staff to give the patient a call. If they've been found that yes, they do indeed meet the DHHS clearance criteria, then the patient will be provided with a clearance letter, and there'll be an email sent back to the GP to inform them that yes, the patient's been de-isolated. They've therefore also been discharged from the COVID care pathway, and then also the patient will receive a text message to say, yes, thank you for having taken part. No longer need to follow up through our digital tool, and any further care can be through routine paths. Speaking of which, in terms of post-COVID care, so really that's a return to routine follow-up and management. But I think it's just worth noting that we do have a specialist post-COVID respiratory and infectious diseases outpatient clinic. Now, this is primarily for the follow-up, for the longitudinal follow-up of severe COVID. And so the initial criteria for accessing that clinic are that they've been admitted to hospital and have required supplemental oxygen or been admitted to intensive care. That being said, certainly patients who may particularly those with comorbidities and especially chronic lung disease, even if they have not been admitted to hospital, then there's always the respiratory team are always keen to discuss those patients and potentially review them. And really, this is principally around the long-term sequelae of COVID. I just wanted to mention very briefly in the event that we have a patient who doesn't consent for entry into the pathway, then if we have a GP's details, we'll contact the GP directly and inform them the patient is COVID positive and that they're not consenting for follow-up. And similarly, if a patient withdraws consent during their time, then we'd just appreciate it if the community partners could relay that through to Austin so that we could report that to DHHS. In terms of supports, so certainly there's the documented health pathways as Alison had outlined. We at Austin Health are here certainly for direct clinical support, and then also tech support as well, in negotiating through the use of the monitoring tools. Community health services for the social and welfare supports, and then obviously the PHNs in terms of the pathway support and coordination and education as well. Tech support, really the best option as the first port of call is our COVID call centre. That's where our triage nurses are located as well. So that's where our team that are using these tools day in, day out are located. And then that can be, any more complex issues can be directly escalated through to myself in infectious diseases and also IT. Just to make people aware, really the next steps that we're looking at with the Northeast Pathway, I'm in the process of developing a specialist paediatric module. So this would be for anyone under the age of 16 and really has a focus on more specific paediatric symptoms, and then also has an integrated assessment, integrated survey, really specifically assessing for multi-system inflammatory syndrome, which will then be continued for up to 6 weeks post their acute COVID infection, and that's in the pipe and should be delivered fairly soon. Similarly, really assessing the program itself. So we'll be using these same tools to then develop patient satisfaction surveys that we can deliver after the fact once someone's been discharged, and also monitor for any potential complications long term. So I think the summary really is that in the Northeast, we're using a digital self-reported symptom monitoring system through COVID Care tool with the patient and COVID Monitor to look at that data ourselves. That Austin Health will undertake the initial triage and the de-escalation assessments, but that will have daily clinician review, whether that be at Austin or at a GP or a community health GP, using COVID Monitor to assess any reported symptoms with exactly as Alison had said, a low threshold to escalate for discussion and review. And really our team is very eager to hear from anyone who is caring for COVID patients to assist them and be able to provide increased care if that's needed and advice if it's not. As I've mentioned, so yes, always being aware of the potential deterioration at sort of 7 to 10 days and have a very low threshold for investigating breathlessness or chest pain. And I always want to hear about that, so you're welcome to call me. And that's really a reminder that digital tools are really designed to assist in the triage or review and not replacing emergency services. So in all of our messaging to patients, this is not the equivalent of calling the ambulance. If they think they need an ambulance, that's what they do first. And just some reassurance, though, that the majority of low-risk patients will remain clinically stable and have done since the end of March when we've been following them here. And that we continue monitoring them until we've de-isolated them and cleared them.